Hey guys, it's Olivia. Welcome back to your endocrinology chapter. In this section, we'll be talking about hypercortisolism. Hypercortisolism is an excess of the hormone cortisol. It's also referred to as Cushing's syndrome. And hypercortisolism is a very common pathology that you are very likely to see while you are treating patients, regardless of which specialty you go into. Of course, because we are talking about cortisol, we are talking about our corticosteroid pathway over here. We'll quickly review. Our hypothalamus releases CRH. CRH travels to our anterior pituitary. Our anterior pituitary is going to release ACTH. ACTH will travel to our adrenal cortex, and it is going to be that zona fasciculata of your adrenal cortex, which of course will release our corticosteroids. All levels of these pathway are going to exert negative feedback on the previous level of the pathway, and that is how we control cortisol release in the body. But what are the causes of too much cortisol in the body? Well, the first cause, or the primary causes, is going to occur at the level of our adrenal cortex, that zona fasciculata. And primary hypercortisolism can be caused by adrenal adenoma, so a tumor of your adrenal glands that is going to be secreting cortisol, adrenal hyperplasia, so just hyperplasia of these glands secreting too much cortisol, carcinoma, all of these things that can release too much cortisol and are not listening to the regulatory steps of this pathway. They're just excreting it on their own. And then in most of these pathologies, since we're only involving the one affected adrenal gland, of course there's going to be atrophy of the uninvolved adrenal gland. And if you understand this pathway, that should make sense to you, right? Because there's a ton of negative feedback here. We have a ton of corticosteroid going back and exerting this negative feedback on these different levels of this pathway. So we're going to have very decreased levels of ACTH and decreased levels of CRH because of this negative feedback. Thus, there's not going to be any stimulation for this other adrenal gland here. This unaffected adrenal gland that is listening appropriately to the pathway is not going to be producing any corticosteroid, and that is why it's going to be atrophying. So that is the mechanism of the atrophy here of the uninvolved adrenal gland. Our next cause of hypercortisolism is going to be the exogenous use of corticosteroids, most frequently prednisone, but there are other corticosteroids that people are prescribed for a variety of reasons. Corticosteroids are an immunosuppressant agent, so they're often used for the treatment of autoimmune diseases like rheumatoid arthritis, Crohn's disease, lupus. So there's a wide array of utility for these drugs, and when they're administered exogenously, they are of course going to cause hypercortisolism, which is very similar to primary hypercortisol, which is why I've included it down here on your diagram, kind of at the same level here. Because we're going to have this increase in corticosteroid, again, we are going to see increased negative feedback on your pituitary and on your hypothalamus, so you are going to get widely decreased levels of ACTH and CRH. Because you are having this decrease in levels, you are again going to see that adrenal atrophy. But an important distinguishing factor here is you will see bilateral adrenal atrophy. And that makes sense, right? It's not that just one of your adrenal glands is over-secreting cortisol. In this case, it is that we have an exogenous source of cortisol. So both of your adrenal glands, which are controlled by this pathway appropriately, are going to be secreting less cortisol since you're already getting it from outside the body. The next cause of hypercortisolism that I want to talk about is Cushing's disease. Unfortunately, there's not another name for this process at this time. And Cushing's disease is a very specific type of Cushing's syndrome that occurs at the level of the anterior pituitary. So your anterior pituitary is what is affected here. You are going to have an ACTH secreting pituitary adenoma. So this tumor of your pituitary is going to be secreting a ton of ACTH. Obviously, ACTH levels are going to be elevated, and that is what is going to trigger your adrenal cortex to release increased levels of corticosteroids. Now, because both glands here are going to be stimulated, because they're both stimulated equally by this elevated ACTH, you're going to see bilateral adrenal hyperplasia in Cushing's disease, which is very different than primary hypercortisolism or exogenous corticosteroid use, where you had atrophy of one or both glands. And then while Cushing's disease is a secretion of ACTH from the anterior pituitary, you can also get ACTH from other sources. So small cell lung cancer, bronchial carcinoids, several other tumors can also secrete ACTH, and they can create this paraneoplastic syndrome that looks exactly like Cushing's syndrome, wherein the ACTH that they are secreting is going to lead to elevated cortisol and that bilateral adrenal hyperplasia as well, because we have too much ACTH. So it's important to remember that you can have this ectopic ACTH secretion, very commonly tested with small cell lung cancer. Here I've drawn in a mass on a lung to help you remember that ACTH can get secreted from these different types of tumors at different sites in the body, causing a presentation that is very similar to Cushing's disease. A quick note here, because ACTH is encoded for by the POMC gene, which also encodes melanocyte-stimulating hormone. These pathologies that are going to cause increased ACTH release, you may also see elevated melanocyte-stimulating hormone, which will lead to increased melanin production, which can cause hyperpigmentation, which is one of the symptoms that you may see, not always, but again, you may see that symptom in a patient who is presenting for a type of hypercortisolism that also involves increased ACTH release. Now, how are patients with hypercortisolism going to present? Well, there's a very classic presentation for hypercortisolism. First, there are these moon facies, which basically mean just edema and widening of the face. If you look down here at this patient, you can see there is more of a rounder facial appearance, as well as weight gain, hyperglycemia, and insulin resistance. Remember, cortisol is very important for glucose release into the bloodstream, abdominal obesity, and then a dorsocervical fat pad. So that is going to be a fat pad kind of between the shoulder blades. It was previously referred to as a buffalo hump. Please don't ever tell a patient that they look like they have a buffalo hump, but you may see that language used on step 1. You may also see purple striae or skin thinning. And if you look down here, you can see these big purple stretch marks. This is very classic for the type of striae that you will see in hypercortisolism. This purple dark color and these very large stretch marks, that's going to be more classic of hypercortisolism than maybe the white stretch marks you might see as a result of growth or pregnancy or other causes. You might see amenorrhea, hirsutism, and osteoporosis. And the presentation of hypercortisolism is, of course, most of the side effects that are going to occur with long-term corticosteroid use to treat other diseases. And I think it's just important to mention that while a lot of these parts of the presentation are not dangerous, they are, of course, very difficult to live with and can drastically impact a patient's quality of life if they do have to be on these medications long-term. Now, what are the diagnostics for Cushing's syndrome? Increased 24-hour urine-free cortisol and increased late-night salivary cortisol are going to be pretty ubiquitous to any of these pathologies just because they reveal an increase in cortisol, which of course is what's causing the presentation. This is a hypercortisolism. So these are going to be pretty much elevated across the board. Then we also have our low-dose dexamethasone suppression test. And basically what we do is we give a small amount of dexamethasone, which is of course a different type of steroid hormone that should be suppressing this pathway. And then we measure the levels of the other hormones in this pathway that should be getting negative feedback. Now, the low-dose dexamethasone suppression test can detect elevated ACTH release. And so if we give the dexamethasone and we don't see any decrease in cortisol, that means that we have a hypercortisolism because we're not listening to the negative feedback in this pathway, so we know there's some sort of dysregulation. It's not very helpful, however, for telling us what type of dysregulation we have. The high-dose dexamethasone suppression test, however, is important for this discernment. The high-dose dexamethasone suppression test is going to detect a pituitary etiology. So if we give a huge whopping dose of dexamethasone, then we see decreased cortisol after we have given that dose. That's because if we have an anterior pituitary pathology, all these cells producing the ACTH are still in the anterior pituitary, then those cells can listen to a huge amount of cortisol. They may not care if it's a small amount of cortisol and may not respond to the low-dose dexamethasone suppression test, but they still have those receptors that can detect a huge increase in these steroid hormones, and thus if we give a whopping dose of dexamethasone, that should go to the anterior pituitary cells, tell them to shut off for a little bit. We should get decreased ACTH release and subsequently decreased cortisol, and that's how we know if these cells are in the pituitary. If these were ectopic cells, for example, they importantly do not have that receptor to detect the negative feedback from the corticosteroids, so they will not respond to dexamethasone, and that is why you'll see this difference here. If we have ectopic cells, there will be no decrease, but if this is a pituitary etiology, we will see a decrease. Some other important laboratory tests to keep in mind: if we have exogenous steroid use or an adrenal tumor, we're going to have increased cortisol levels, late night salivary, and 24-hour urine cortisol. We're also going to have decreased ACTH. Negative feedback is still intact. And then an important diagnostic step here, if you are thinking it's an adrenal tumor, is to get a CT with contrast for adrenal mass. So CT with contrast usually is looking for a mass. Without contrast can be better for blood products. Of course, if this was exogenous steroid use, you should look for causes of exogenous steroid use in the patient's history, and that would be a way to distinguish between these two because they do have very similar lab values. Cushing's disease, again, you're going to have increased 24-hour urine cortisol, late night salivary cortisol, and then here you're actually going to have increased ACTH. So increased ACTH here instead of decreased ACTH. That, of course, is because this is a pituitary mass that is secreting the ACTH. You're going to see suppression on your high-dose dexamethasone test, and that's really important because that's what's going to tell you that this is a pituitary etiology. Similarly, on the CRH stimulation test, where we're just giving some CRH and seeing what happens downstream in this pathway, you are going to see a response. You're going to see increased ACTH and increased cortisol. That is because CRH can still trigger the anterior pituitary because it's those cells that are in the anterior pituitary that are still responsive to this pathway, even though they are making too much ACTH. And so you will see downstream effects here with the CRH stimulation test. Finally, if you did a pituitary MRI on this patient, you may very well see a mass in the pituitary that is these cells that are secreting too much ACTH. For our paraneoplastic syndromes, things like small cell lung cancer causing this ectopic secretion of ACTH, you're of course going to see that elevation in urine cortisol and late night salivary cortisol. Again here, you're going to see increased ACTH, but this is a little bit different because this increased ACTH is coming from outside of the pituitary, so there's no pathway control because these cells don't have the receptors to detect CRH levels or cortisol levels. That is why our high-dose dexamethasone suppression test here, you're not going to see any suppression because these cells don't care how much cortisol is being released. They don't have receptors to detect that and are not going to respond to negative feedback. Similarly, our CRH stimulation test, there's going to be no response because, again, these cells are outside this pathway. Imaging here, again, is going to be important. If you have a paraneoplastic syndrome, you need to know where that malignancy is coming from. So you can do a CT chest, abdomen, and pelvis, just looking for masses all over and figuring out, is this a lung cancer? Is this bronchial carcinoids? Where is the tumor? And then finally for management, it's really going to depend on what's causing the hypercortisolism. So if it's a neoplasm, treat the underlying neoplasm. If this is caused by exogenous steroid use, then cease the exogenous steroid use. Of course, this is easier said than done. Of course, some patients need to be on these medications for other underlying conditions. So balancing the lifestyle cost and the importance of them being on this medication to manage other conditions is very challenging for a lot of patients. And then finally, there's several drugs we can use to reduce either ACTH or cortisol levels. Ketoconazole can reduce ACTH secretion as well as cortisol levels. Metirapone and mifepristone have also been known to reduce cortisol levels. That's all I have for you guys on hypercortisolism. Thanks for watching, and I'll see you next time.